So the history of the heart team, just to kind of go through where this idea came from, it originally arose from tumor boards, where oncologists, surgical oncologists, radiologists got together in a room, discussed complex cases, discussed what treatment options were available and what would be the right thing for the patient. Has moved into cardiology in transplant as well as complex congenital heart disease, again for these complicated patients. In terms of coronary disease, it was originally there and then sort of went away and came back with syntax when we realized that these decisions could be improved when putting more than one mind on the case. And as a result, it's moved into the TAVR world. And in our guidelines, it states as a class 1 indication that patients with severe valvular heart disease should be evaluated by a multidisciplinary heart valve team when intervention is considered. Obviously, this is a level of evidence C. I'm going to go through what some of the evidence that we do have to support the use of the heart team in valvular heart disease. Also important, this is highlighted in the Medicare National Coverage Determination as important for reimbursement. The potential benefits of heart teams is that it can obtain broader input into complex decisions, allow more intricate and patient-centered treatment plans to be developed, facilitate shared decision-making, improve coordination of care, and minimize concerns of physician self-referral, which is a big issue in PCI particularly. But is there any evidence that these heart teams impact care, or is it something like cough syrup or incentive spirometry, something that sounds like a good idea, but we really have no evidence that it actually does anything to improve care or outcomes? There was a nice editorial from Brahmaji and Dave Cohen in 2012 that stated, in addition to designing and implementing innovative organizational models for incorporating heart teams into care pathways, we need to develop an evidence base for understanding how these approaches improve care and what specific operational and structural factors are most central to this success. So this is calling for some additional data to say, do these work? And if they work, what parts of them are most critical? So in terms of the data, there really isn't a lot of data in terms of the valve disease, and I will fully acknowledge that. But we do have some evidence that heart teams are effective in complex coronary disease, and I'll go through some of that. So the first thing that heart teams can do is they can improve data interpretation. This study looked at 308 angiograms of patients from 15 hospitals in New York. They were reviewed by a blinded panel of 3 interventionalists at an academic center. They found that 4% of the angiograms were deemed uninterpretable. Almost half had technical difficulties. When they talked about the degree of stenosis, there was only 70% agreement overall. And when they limited this analysis to those segments or those vessels that had some stenosis, this agreement was reduced to 51%. Local cardiologists tended to state the severity of the stenosis was greater. 23% of the cases, they were thought to have more extensive disease than the panel, and less extensive in 6% of the cases. And the implications of this are real. This is looking at the local assessment of the need for CABG, whether or not this was necessary or inappropriate or uncertain or inappropriate. When the local cardiologist thought that CABG was inappropriate or uncertain, the panel generally agreed. But in 33% of the cases where the local cardiologist thought CABG was necessary or appropriate, the panel thought this was uncertain or inappropriate. And furthermore, 17% of the patients who underwent CABG were deemed as uncertain or inappropriate by the panel. So this goes to the aspect of having multiple people review the data may improve interpretation. The second way that heart teams could be impactful here is to reduce variability. This is looking at the rate of PCI versus CABG across different countries. And overall, PCI versus CABG was chosen 3.3%. The ratio is 3.3. But this varied substantially across countries, and this is not likely to be driven by patient characteristics alone, but instead due to local practice patterns. And furthermore, people tend to not even discuss the alternative treatments. 68% of PCI patients, 59% of CABG patients reported no discussion of alternative treatment options. And this goes to the aspect of physician self-referral. And importantly, when you have more than one person discussing these options with a patient, you arrive at a more informed decision. This can improve with further discussion. This was kind of a hypothetical study where they took 6 different patients. They had 2 or 3 vessel coronary disease, and they presented these cases to 8 surgeons, 14 interventionalists, and 31 non-invasive cardiologists. And they asked these doctors, what is the best treatment for this patient? These patients varied in terms of their age, their presentation, stress tests, LV function, coronary disease severity, comorbidity, and number of anti-anginals. So for example, they would say this is a 64-year-old patient with obesity and hypertension, with stable coronary disease, positive stress test, normal EF, 3 vessel disease, and on 2 anti-anginals. And they would ask these physicians, what is the best treatment for this patient? Not surprisingly, surgeons felt that CABG was most appropriate in the majority of patients, whereas interventional cardiologists were more likely to favor PCI and non-invasive to favor medicines. The agreement across the physicians was only 0.26 in the first round of voting. When they allowed for open discussion, so an exchange of ideas among these physicians, this did improve to 0.44. So again, highlighting the way that heart teams could improve patient selection by reducing variability. Heart teams can also improve complex decisions. In the EAST trial, there was, among patients who were randomized, there were similar outcomes between the treatments. But of the eligible patients, 450 did not enter the trial due to a strong physician or patient preference that one treatment was most appropriate for that particular patient. And in these registry patients, survival on angina was better than in the trial patients. Similarly, in Barry, similar outcomes between the patients in the trial, but nearly half of the patients were felt to be better treated with one treatment or the other. And again, survival on angina was better in these patients. So I think this highlights the way that heart teams and these complex decisions could be improved by having more than one person involved in the decision process. So the proof that heart teams work, at least in coronary disease, is that team review can improve interpretation of data that impacts treatment choice. Team review can reduce inherent biases in treatment choices and reduce variability. And team review can improve outcomes by identifying patients who may benefit more from one particular treatment. But the real question here is, does this also apply to TAVR? Well, I would argue that the decision to undergo TAVR is inherently complex. These are the outcomes of patients in the major trials, as well as most recently in TVT. This is looking at a combined outcome of death or persistently poor quality of life at 6 months in the first 2 bars and at 1 year here. And we see that a third of patients have a poor outcome at 6 months, and nearly half had a poor outcome at 1 year. This has been improved with TVT, but again highlighting the complex decisions on whether or not to undergo TAVR in some of these very frail elderly patients. There's been a recognition by practitioners and the FDA and CMS that we should not be doing TAVR in these patients, but how to identify them is complex, and I think really requires a multidisciplinary approach. The TAVR procedure is inherently complex. While this has been improving over time, there are still challenges. This is a study from the high-volume German TAVR Center, where they had over 2,000 patients treated from 2006 to 2013. And they found that nearly 11% of the TAVR procedures required surgical intervention. And they estimated that around 1 out of every 1 to 200 patients is saved because immediate surgical intervention is available. So finally, I would argue that heart teams are valuable if the heart teams themselves find value in them. This was a study that Dave Cohen did, a small qualitative study of interventional cardiologists and surgeons from experienced TAVR centers. You can see their volumes here. 64% had a multidisciplinary valve clinic and 86% had a regular valve conference. This is where those physicians came from. And the physicians were asked, what are the top 3 pieces of advice for a new center that is just starting a TAVR program? And these are the things that they listed. Centralize coordination and communication, cultivate a spirit of mutual respect and collaboration, obtain buy-in from all parties, clearly define roles and workflow, establish a shared financial model, keep everyone actively involved, establish a true multidisciplinary valve clinic, and learn from each other, as no one knows it all. So I think these things highlight the value that heart teams really place in them. So my arguments for a heart team is that patient selection is inherently complex. The choice of any intervention or no intervention, as well as the choice of type of intervention. Treatment planning is complex. There are different valves, access sites, and anesthesia, and getting multiple people involved in this decision may improve outcomes. And finally, complications requiring surgical intervention are still common. And so I would argue that until TAVR becomes a standard of care, and until complication rates are sufficiently low, heart teams do have value. Thanks.
So why did we start with heart teams? Physicians have a different skill set, and this is historical. I mean, we have interventionalists and cardiac surgeons from day one after med school. They take completely different pathways, end up treating the exact same patients, but they have a different skill set. And so these new procedures, these new valvular procedures, didn't really fit neatly into one specialty. You wanted the kind of surgical experience with the disease state as well as the anatomy, but you also needed the interventional skills in terms of the 2D imaging, and certainly the wire skills. And in fairness, especially with AS, the established surgical procedures work really well. This wasn't like we were taking stage 4 lung cancer and anything we have that'll work, let's give it a try. I mean, we already had something that works very well. And so really the heart team was formed to help define the procedure and end the patient population, because we didn't want to do this inappropriately. So and I'm focusing obviously on TAVR for the time being, but I'll address mitral briefly, but the TAVR procedure, kind of when it first started, it was initially done with femoral cut downs. Transapical, transaortic, subclavian were frequently used options. I mean, in the early experience, TA was up to 40% of the time. And like I said before, surgeons had the surgical skills, interventional cardiologists had the catheter skills, and there was really not much overlap. I mean, there weren't a lot of surgeons who had the wire skills, and certainly the interventional cardiologists who had seen the 3D valves. And there were a lot of bad complications. Okay, this is our early experience with the initial Edward sheath that was 24 French with sandpaper on the tip, and these are the kind of things you'd see. And when this happened, you want to make sure your surgeon's in the room. But the procedures change. So there's a decreasing use of the non-TF approach, as Mike talked about earlier. I mean, we're actually well less than 2% now. Everyone else is transfemoral now. And personally, I think it's better to have a vascular complication than to do a transthoracic approach, provided you can fix it, of course, if it happens. We're doing it percutaneous now. We're not doing cut downs. The interventional cardiologists have become more comfortable with the large vessel access, with the larger complications. I mean, it used to be they'd leave crying when something happened because we were used to it all the time as surgeons, but they're used to it now. And the surgeons now have some catheter skills, which is new. And the complication rate is certainly much lower, and most of them are really manageable endovascularly now, and I'll go into that. I'm going to just show you some data on some of this. Now, I wanted to have some stuff that Suzanne could understand, so I put some stuff from her partner Dave Cohen, but this is just to show that these non-thoracic approaches really need to be abandoned if possible. This is from the original partner 1A study looking at the transapical group compared to surgery, and in terms of quality of life metrics, early on they actually did worse. So the TA patients did worse than surgical AVR patients, and there wasn't an advantage there. I mean, the TF patients, they're spending less time in the ICU. Here they weren't spending less time. The costs were, well, not significant. It was more expensive for a transapical procedure than an AVR. And so when you have this, when you plot out the quality of life versus cost, TA and the other approaches were this is the bad corner. This is not the corner you want to be in. More expensive, less quality of life advantage. You want to be here that's less expensive with a more quality of life advantage. And this is where transfemoral TAVR did end up. And we know now that transfemoral TAVR, actually, if you look at, core valve studies showed superiority over surgery in their high risk. the partner did not, but if you take the TA patients out of it, actually there was a survival advantage both in intermediate and high-risk patients with this approach. There is data looking at percutaneous versus surgical cutdown. This is from Cedars, and they showed that there was more bleeding, wound infections with surgical cutdown as opposed to percutaneous. There was actually a length of stay advantage to doing it percutaneous over a surgical approach, and with time, the vascular complication rate came down. I mean, we've done, I think the last time we had to do in 350 patients at NYU, we've done one cut down, and that was a planned procedure because they needed a femoral endarterectomy at the same time, but we've not cut down on anyone. And there's other people, and this is early experience, but very high success rate with the percutaneous approach. So what about these complications? So this is, no, it's not playing. So this is someone who had that kind of picture that I showed you before with the rupture, and now we're able to kind of stent these patients. So we're not, even when they have these mass, which is rare, but even if they have a massive complication from in the retroperitoneal space, we can now stent them and fix that. This is a patient who has an annular rupture. You can see the exsanguination here. As well as a big pericardial effusion. So this is one of the dread complications, annular rupture. But even in this case, we went ahead, took another sapien valve, deployed that. Basically, you turn the first valve into a covered stent by stenting up the leaflets. And so we were able, we had to do a pericardiocentesis, put in a new valve, and took care of it. And this patient survived. I mean, so these are all now. These are, we talk about needing a surgeon for these issues. It's not clear, and this isn't going to play either, I apologize, but so left main occlusion, and those are by and large treated with PCI anyway, should they occur. So we talked about the CMS has this national coverage decision, which there was a lot of things specified in it, but 2 surgeons had to verify that independently examine, verify the patient was high risk for surgery. And this is actually one of I think the most difficult and potentially expensive parts of this procedure, to get 2 people to separately weigh in, have separate notes. But it also mandated that the cardiologist and the surgeon jointly participate in the intraoperative aspects of the procedure. Now, this, as Suzanne even mentioned, this is based on no data. This was really driven by the societies, and in fairness, the societies are doing what they were supposed to do. I mean, this is, I think the surgical societies saved, opened the door for surgery to stay in this, and that was important, okay, at the time. Again, they were doing, but it's not based on, there's no reason we had to do this, that's what they did. And part of it was to really limit there was limited labeling, and so they wanted to, obviously the surgeons wanted to be involved and not see their future go away, but they were determined to be the gatekeeper for these high-risk patients. But what's the procedure going to be like now? I mean, now, we know TAVR is superior even in intermediate risk patients. And let's even address the risk issue. Is a surgeon really I mean, they're certainly good at determining the risk of a patient. And yeah, a surgeon is probably the only one who can look at it and say, this is, this aorta is, calcified in the wrong spots and is going to be more difficult. But I think we're all capable of calculating an STS score and doing the eyeball test. You don't need surgical training to do that. Low risk trials are underway now. And so if we're now doing low risk patients, do you even need a gatekeeper? You don't. If everyone's going to be treated, there's really no role for a gatekeeper, especially a biased one. I mean, Suzanne showed the stuff of inappropriate PCI at New York hospitals, particularly one up above us a little bit in New York, and she's right, but that is an unbiased panel. So if you're proposing an unbiased panel to look at patients, that's okay. But the heart team has people with skin in the game, right? And they may disagree, but if you have people saying, like happened with CABG and PCI, I mean, the surgeon wants to operate, the interventionalist wants to place the stent. So we're not really talking about an unbiased heart team. Do we need to be paying for a second physician to do this? In some cases, Mike is one of the, there's a handful of surgeons who really know and understand and can do this procedure. I mean, he can do this independently, and there are plenty of surgeons and interventionalists for that matter also who are kind of there to deploy the balloon, and that's, you could get anyone to do that. I mean, quite honestly, I'd rather take that money and pay for the for the imaging person who's actually who's probably more important. And Steve, I expect your vote for advocating for paying the echocardiographer more for these procedures, but it's true. I mean, certainly in a MitraClip, they should be paid more than than having a second operator, because they dictate the procedure more than anyone. And what about MitraClip? I mean, patients need to be high risk, but we don't have the same NCD issues now. I mean, you have to participate in TVT, but it's not mandated the surgeon or an IC for that matter be involved with the procedure, even a surgical letter to determine high risk. But if not, a heart team you got to have someone doing this, and it has to be a well-trained individual. You need someone who can handle the whole process. That's including the screening. You have to know you have to know how to read the CTs. You obviously have to do the procedure and manage the post-procedure care. But you have to handle the complications. So you've got to be able to have the peripheral vascular skills. If you have a vascular complication, annular rupture, coronary occlusion, and there are fields. I mean, we can have complications where you have to call other specialists. I mean, we're never gonna, if you have a vascular complication, you want to call your vascular surgeons. They should come help you. If a vascular patient has a STEMI, you're not going to say, no, I'm not going to go take him to the cath lab. I mean, that's just part of medicine. Sometimes you have to handle that. And we're, as cardiac surgeons, if someone has a rupture during a PCI, we're not going to say, no, you should have sent this patient to surgery, so I'm not going to help you with the complication. So should it be a surgeon or IC? I think it'd be either. And I think through this, I've presented this talk kind of unfavorably towards surgery, and I'm a surgeon, but let me be clear, that's not the case. I mean, I think if anything, you could argue maybe a surgeon is even, if you have the appropriate skills, you're actually more qualified to be this individual, because it's more likely for a surgeon to get the catheter skills than the other way. If this is going to happen, the surgical organizations that do the boarding and education absolutely have to radically change, because again, if we're talking low risk, there's no reason for the surgical gatekeeper, and surgeons do not have the training to do this, then we're not going to be involved. And right now the training is still absolutely pathetic for what kind of wire skill surgeons have to have, and we're gonna pay for that in the long run if we don't address it. I mean, you have to have more. There's a requirement for more esophagectomies than there are TAVRs right now to graduate. In fact, there is no TAVR requirement. There's experience with 15 wire placements, which could be a balloon pump or a central line for all I can tell. So, but I think that's so. But I think it's really, you need to have an individual specially trained, and I think we're now, this is a real field expanding, and we're beyond the point of having the interventional cardiologist who's mostly doing coronaries, who dabbles in structural, likewise the surgeon who's doing mostly open surgery and dabbles in the transcatheter space. But I think now's the time. I mean, that's not to say you can't do the others, but I think it's really, this is an established enough field that you need to have someone who is uniquely trained and really specializing in this unique skill set. So the final bit of data, this is from the TCTMD heart team survey, and they surveyed, it was 254 people who are supposedly working in valve heart teams, asked them a number of different questions, but the 84% of them felt that the heart team needs improvement. That it's not even working as one would expect. In terms of whether it's necessary for patient care, less than a third actually felt it was even necessary for patient care. More, but not even half, that it was necessary for professional decision making, and I would argue that's based on mandates from the NCD more than it is anything else. And further to that, they asked at what stage does the heart team need to be involved, and really it's not the procedure they were involved, but it's mostly treatment selection with less input in the other factors. So in concluding, I think the heart team had its day, and it certainly was useful, but I don't think it's longer necessary. I don't think it's going to be cost effective to continue to mandate multiple consults and pay for multiple physicians to be in the room. But I do think that physicians need to kind of focus on becoming specially trained. So thank you.
certainly good points. I think that I fully acknowledge, especially the NCD requirement is extremely excessive in what they require in terms of heart teams. I would argue that we're not there yet in terms of saying the heart teams are not quite. We may be. I think maybe in 10 years when we have this specialty of TAVR that is being trained with both surgical skills as well as advanced structural skills, that second operator in the OR, the hybrid OR, the cath lab will no longer be necessary. But I don't think we're there yet, particularly when, as we move to lower risk patients that have fewer complications. As somebody I was talking to a couple days ago had said that it's like getting on a plane and not having a co-pilot, and that co-pilot is rarely necessary. They may not be necessary, but who wants to be on a plane without a co-pilot? When those few times where something really happens, it's really helpful to have that person there. But I agree that I think the NCD went a little bit too far, particularly given where we are now.
Don't want to discredit my talk, but I mean, I certainly do think there is value to the heart team, and I think really the best way to have a functional heart team is if you're able to really combine the specialties into one group, and you take the financial incentive out of the decisions, and that you just want to, you want your group to ideally treat the patient, but treat them the best way that it should be done.